go ahead and get started. So I'm Sarah Radcliffe. I'm a lawyer with Disability Rights Oregon, and I'm going to be presenting today. Do you guys want to just introduce yourselves real quick? And then
Certainly.
I'll
Good afternoon. My name is Mike Reese, and I'm the sheriff of Multnomah County.
Good afternoon. My name is Nicole Morrisey O'Donnell, and I'm the Chief Deputy, part of the Corrections Division, the Services section of the Corrections Division.
So we're here a little over a year ago. Disability Rights Oregon, actually about exactly a year ago, Disability Rights Oregon released a report about conditions for people with mental illness in the Multnomah County Detention Center, which is the downtown jail in Multnomah County. It's in the Justice Center building. And after the release of that report, we've been working with Sheriff Reese and also the health department around improving conditions, and there's a lot of work that's been done. So we're here today to give you an update on kind of progress 1 year after the report, what's happening, and where there are still areas for improvement. So just a quick background about Disability Rights Oregon. We're a nonprofit law firm. Every state has a federally designated protection and advocacy system for people with disabilities. There was created by Congress in the 1970s, and with that, we call it P&A for short, but with that designation, we have statutory powers to safeguard the human and civil rights of people with disabilities. We can also investigate allegations of abuse and neglect, monitor basically any facility that cares for or confines people with disabilities, and get records. And feel free to just interrupt along the way if you all have any questions. We're each going to talk for about 20 minutes, and then we'll have a lot of time for questions, but if anything's not clear along the way, just jump right in. So DRO we're a client-driven organization, and our kind of core principles are community integration, so keeping people in their communities rather than institutionalizing or criminalizing people, and then we're focused on individual rights and choice. There's a picture of a person at MCDC. So in our report, we identified three main areas of concern, and some of these are areas that are concerning basically in every jail across the country. And so I'm going to go through each of those areas of concern and then dig down a little deeper and then let you know what's happening. So we've been hearing a lot today, and I think everybody knows far too many people are in jail because of behaviors related to mental health crisis. At MCDC, there are 138 designated mental health beds, so that's bigger than the Unity Center for Behavioral Health. And there's also a really high volume of people who are circulating through our jail system. So about 1.5 million people are discharged each year from state or federal prison, but there are 10.6 million admissions to jail. So that's so many people that are cycling through jail. And what we see for a lot of our clients is that they're serving what I've heard called a life sentence on the installment plan. So we think of jail as, well, it's just a short-term stay, 7 to 10 days maybe. So, we don't really need to worry too much about conditions or what people are experiencing in there. But actually, a lot of people are admitted multiple times during a year to jail. So they're spending a lot of time in there in short segments. Also, about half of Multnomah County jail beds are dedicated to probation violations. So that may have been a minor crime to start out with. A person got probation. But what we see for our clients is that if you have an addiction issue, if you're homeless, if you have a mental health problem, if you don't even have a cell phone, your barriers to complying with the terms of your probation are really high. So probation might be kind of setting our clients up to fail and just, kind of be stuck in that cycle of incarceration. So I think that's really an important piece for DAs to register, because when we talk about criminal justice reform, sometimes we think, well, DAs can be, really lenient by offering probation, and then the person will get their life back on track. They'll comply with the terms of probation, and then the criminal issue will be over. But what we see is a lot of people are spending a lot of time in jail for probation violations. It's really hard to hold down a job, to keep custody of your kids, to keep your apartment. Any of those kinds of stability factors are hard to maintain if you're interspersing that with periods of time in jail. I also want to address, I think we should all be skeptical when we hear the term forensic population, because really, whether you end up in the criminal justice system or the clinical system, I think has a lot more to do, with all kinds of demographic and social factors, and it really has to do with whether a particular behavior that you're engaged in is criminal or mental health related. I mean, there's really a lot of crossover between these two systems. And it's important to be aware of the role of race. So African Americans are about 6% of Multnomah County, but are 19 to 20% of people who are booked into Multnomah County jails. And the one study that I'm aware of that addresses, that looked at mental health in Multnomah County jails found that in that particular sample, which was a random sample, African Americans made up 40% of people in the jail with serious mental illness. So to go from 6% to 40% is a drastic overrepresentation of Black people with mental illness in our jail system. So I always like to start with a story. So this is a former client who I'll just call Carol Spivey. And this kind of illustrates why people get sucked into the system and how hard it is to get out and how much time they spend in the system and how traumatizing it is. So she was charged with some misdemeanor charges related to theft and interfering with public transportation, and she was unable to aid and assist in her own defense. So because of her mental illness, she wasn't able to help her criminal defense attorney. So she went to the state hospital in the fall of 2014 and spent 8.5 months there trying to restore competency so she could face her charges and wrap up her criminal issue and move on with her life. She would have been really receptive to any services that might have been made available to her. Things like she had a history of homelessness, so she was discharging to homelessness. She would have loved to get into housing, to have community mental health services, to get into addiction treatment, anything and everything. She really was motivated to try to regain custody of her kids. But as is the usual when people go through the competency restoration process, after 8.5 months in the state hospital, she was competent and she was discharged to nothing. So she was homeless. She was struggling on the streets. So after that discharge, she was out for 2.5 months, and I looked at her OHSU records. She presented at the emergency department 7 times during that 2.5 months. On the final time, she came to the ED saying that she had been sexually assaulted. They did a rape kit and a CAT scan because she had a head injury as well, and then she was discharged. 6 hours later, she was found sleeping in a different part of the hospital, and the hospital police ran her name and found that, guess what? A warrant from over a year ago hadn't been cleared, even though she had been through the whole system. So she was arrested on that old warrant, another interfering with public transportation warrant, and she went back to jail. She spent 4 months in jail before she was found not competent to aid and assist and sent back to the state hospital where she spent another 4 months. So it's just months and months. And, to look at her jail records, and this is from the fall of 2016, so we're talking, I guess, 1.5 years ago. But to look at her jail records is just crushing. She was in solitary confinement. She wouldn't shower. There are notes saying that her room and her person smelled like a dumpster. She was often noted as, quote, too unstable to walk, which means that her psychiatric symptoms were so intense that deputies felt it wasn't that they couldn't let her out of her cell. And we all know that solitary confinement exacerbates mental health issues. So the more she was kept in her cell, the more, the worse her condition got. So I think it's important to just like grapple with that reality of what it's like for people in the system. So how do we decriminalize mental illness? So that was, when we wrote the report, we really wanted to focus on the continuum. So it's not just jail conditions, it's how do we keep people out of jail? One point that it's important is that decriminalizing mental illness means no criminal charges. So that's my confusion around mental health courts as playing a role of decriminalizing mental illness. I'm not quite sure how that works, because if you're in court and you're facing charges, then even a specialty court seems to be part of criminalizing mental illness to me. But a few principles to keep in mind. So care should be community-based, not in a jail, not in a hospital. We need to make sure that that continuum of care is available. Trauma-informed, meeting the whole needs of the person. We need more care that's available that's based on a harm reduction philosophy. So meeting the person where they're at and providing whatever services they are interested in receiving, allowing them to kind of set the vision for what they want to see in their lives. So that's kind of the big vision. How do we kind of get into the weeds and figure out what decriminalization would look like? So one of our recommendations is more diversion programs, and that's something that the sheriff has really taken a lead with. There's a new Cascadia Behavioral Walk-in Clinic diversion program, so it's kind of like LEAD, only LEAD is for people who'd otherwise be facing charges for small amounts of controlled substance possession. This diversion program is for mental health-related charges, so trespass, disorderly conduct. So I've kind of gone through and made some columns. So what was the recommendation? What's happening on that front? And then what are kind of issues that are still percolating that we're thinking about? So it's important to have good data to track these programs to see whether they're effective. We also need to be mindful that any program that's driven by individual officer decisions, officer discretion, is going to allow a role for bias. And that's not, I'm not calling out law enforcement in particular necessarily, but we just see in any system where you have individual discretion, you're going to have bias. So we need some kind of system for counteracting the role of bias. There's also a lack of community resources. Any of you who work in this field know that it's great to keep them out of jail, but then what? Is there housing? Is there community mental health? So we need more community resources. Am I going too fast, or is this pretty good? Okay. So our other recommendation around diversion is jail gatekeeping. So the jail has an obligation not to admit anyone whose physical or behavioral health needs the jail's not equipped to meet, which sounds good in principle, but actually the logistics of how to make that happen are tricky. So what we've suggested and what other groups have suggested is having a nurse or other qualified clinician as the first point of contact at booking, so that you do a screening, see whether the person's appropriate for the jail before admitting the person. But that's complicated for a few reasons. One, it would require law enforcement to wait in order for the person to be cleared before they're booked into jail, whereas right now, hospitals can be a longer drop-off process, but jail is pretty quick, so the officer's back in the field. This would make that longer. There's also just architecturally isn't really a place for a confidential appointment to happen. The booking at MCDC is like an open booking process, so people are booked and then are going through kind of the various things that need to happen. So some logistical issues there, but we think it's really important to keep people out of, kind of guard that front door of jail, because once the person's in custody, the options are, it's kind of like that train has left the station. There are a lot fewer things that can happen. What we've also seen work in other communities is a non-hospital behavioral health crisis center. So like the psychiatric crisis center in Salem is a a good model, or Centerstone in Clackamas. And that's a place, ideally it would be 24/7, and it would have some housing or respite housing or shelter available. And that would be a place for people who don't meet hospital level of care criteria but shouldn't be in jail and need something. So that's really kind of a gap in our current system. And more housing. So let's see, the second issue that we looked at is, all right, once people are in jail, we know there are way too many people in jail with mental illness. Once they're in there, what do they experience? And pretty much the de facto placement for people with mental health issues in jail is solitary confinement, because their behaviors make it hard for them to get by in general population. But people with mental health issues should not be in solitary confinement. There's a lot of research on how detrimental solitary confinement is for people's psychological well-being. That's what a cell looks like at MCDC. So we made some specific recommendations around ending solitary confinement. The first one's pretty obvious: increase out-of-cell time. So let's try to get people out of their cells more. A year ago, people with mental illness, so there are 138 people in the jail in units designated for people with mental illness. They were getting out sometimes not at all, sometimes 15 minutes a day, an hour a day. Now the sheriff's office has changed policy so that they should be getting out 2 to 4 hours a day, and if they're not given that 2 to 4 hours, then that should be documented and a supervisor should approve, correct? So that's an improvement. It's 2 hours out of cell a day is still kind of, under most definitions, considered solitary confinement, so it's a far stretch from the ideal. This same population of people, so the aid and assist folks, are going to the state hospital, and when they're at the state hospital, nobody's locked in a room without a doctor's order. So we'd like to see more, but that's an improvement. And so what are the challenges? Why is it so hard to get people out of their cells? The staffing ratio is important. The architecture at MCDC makes it really difficult to get people to and from one spot versus another. It's a lot of elevator rides. It's a high-rise building. The recreational space requires an elevator ride. So those are some challenges. And then I think also, jail is just not a therapeutic environment. And I think, we certainly wouldn't object to painting the walls or piping in music, doing some of these things to soften the environment, but you're never going to make jail a therapeutic treatment environment. And I don't think it can ever be trauma-informed, partly just because, of the power differential between staff and inmates. We also wanted to see increased access to health care and mental health counseling. Some programming has been introduced at MCDC. Also, a mental health sergeant and deputy were hired, which allowed the clinic hours to be doubled because there is more availability of escorts to and from the clinics. There's also some new medical staff that was hired, mental health staff that was hired. So those things are real improvements. The architecture still remains a barrier. There's no space on the units for confidential appointments with clients or for programming, so that's still a challenge, which brings us to, that's a picture of a food port or cuff port at MCDC. When we did our investigation, a lot of the contact with mental health staff was happening via one of those cuff ports. So it's hard to make eye contact. It's hard to hear your client. It's hard for them to hear you. There might be a lot of other background noise. So the architectural barriers that I've referred to are the reason that one of our recommendations was move people with mental illness out to Inverness, where there's There's access to fresh air and outdoor space on every unit. There's access to programming space and space for appointments. This is an idea that hasn't been supported mostly because of the just kind of logistics with the physical space at Inverness. They're either large dorms or there's a large cell block unit, but it's probably too large to house a lot of people who are experiencing active symptoms. Okay, this is the last area. Sorry, I feel like this is like a wall of words. Thank you for for sticking with this. So we found that people are put in conditions that are known to exacerbate their symptoms, and then when they experience those symptoms, it was responded to with punishment and force. So we looked at 3 varieties on that theme: restraints, violence, discipline, and punitive suicide prevention protocols. So we looked at restraints. When we investigated, 61% of the restraint incidents were designated as voluntary, which the sheriff's office agreed was seemed a little funky and suspicious. And also African Americans made up 34% of people who were voluntarily restrained, so a big race disparity. So now the jail no longer considers any use of restraint voluntary, and that's important because it's an incident that would be reported then and would go up the chain of command review. And also the jail has cut its use of restraints in half during 2017. For anybody who's familiar with restraints in a clinical setting, though, jail restraints still feel pretty bizarre because there's no clinical involvement necessarily at all, and it's just much, much less regulated than in a clinical setting. That's a restraint chair. We were also concerned about violence against inmates. MCDC houses a third of jail staff, or of jail of jail inmates in Multnomah County, but accounts for 83% of the uses of force. And what the sheriff's own consultant found was that probably these incidents involving uses of force are driven by excessive lockdown time, because if you close somebody in a cell for a long period of time, that tends to make them feel amped up, but they don't have an outlet for it. It just kind of fuels a bad cycle. So the sheriff's office has done some CIT training, de-escalation training, suicide intervention training, mental health first aid. So those are some positive improvements. And then also the sheriff's office is rolling out an employee information system at either the end of 2018, beginning of 2019, that will track uses of force by staff member and also by inmate demographics. And this is kind of a theme that you'll hear is any agency, any jail in particular really needs to track demographics so that, we know that bias plays a role throughout our criminal justice system. We need to have good data so that we can address it, and so that we move away from the individual intent conversation and start really looking at outcomes and disparate impact. And also the jail hasn't been approved to do a $4 million project, which will include installing cameras. Most modern jails have cameras that record. MCDC didn't have cameras that recorded, so it was really hard to prove an instance of officer misconduct or anything else that might happen in the jail. On the issue of discipline, we also found, the sheriff's own expert found that use of discipline seemed excessive. A lot of disciplinary hearings, also disproportionate representation of African Americans in the disciplinary process. What's happening on that front is, so the employee information system will also track staff discipline, and the mental health sergeant is reviewing whether the behavior that gave rise to the discipline was related to mental health symptoms. And there's also a hope that if people are out of their cells more, that's going to help more with behavioral issues. we made some really specific recommendations that haven't been acted on yet. So one incident, one infraction. We saw instances where someone might have, a confrontation related to mental health issues, and then they'd end up with, 7 kind of overlapping infractions. Also, we think there should be shortened time frames, and what we've recommended is no more than 2 consecutive weeks in isolation or no more than 3 weeks in a 60-day period. And then, again, tracking demographics. And the final issue I'll talk about is suicide watch. So suicide watch in any jail or prison setting that I've been in means that if you express any concern about self-harm or suicidality, any behavior in that area, you get a one-size-fits-all approach, which means you lose your visitation, you lose all your personal belongings, you're stripped down and put in a suicide smock and given a suicide blanket. You lose like human contact and the ability to engage in programming and things that might actually make you feel better. So what we've recommended is suicide restrictions should be clinically determined. Like, risk of suicide that's a clinical issue. Clinical staff should do the welfare checks, perhaps rather than sheriff's deputies. And that's an area where we have not seen changes. So that's what I have so far. I have some more client stories, which I think are just a really important thing to illustrate, but I also don't want to monopolize the time. I've already gone over. So I'm going to turn it over to Sheriff.
Great. So thank you very much for being here, and I really appreciate the opportunity to come and share some of the challenges we face in running the largest jail system in the state of Oregon, and also just to share with you some of the good work we've done as well. And somehow with the aid of modern technology, our screen is ready to go. So I'll just jump into it. And I appreciate Sarah and DRO for the work they're doing as well. I feel like we're kindred spirits. We all want to do better and to have a jail system that is safe, that helps people heal when possible. I'm going to share a little bit about our jail system and some of the numbers that go along with it, because I think you'll be surprised at just the volume and the number of people coming through the largest jail system. I want to say we're not afraid to take a hard look at ourselves and to be critical of the work we do in an attempt to continuously improve our processes and to build on the work that we're doing with our staff. So a little bit about our agency. I think it's beneficial when talking to community members, because a lot of people think, what does the sheriff's office do? I was chief of police for the Portland Police Bureau for 4.5 years and was in that system for 20 years. And a lot of people know what the Portland Police Bureau does, but not a lot of the sheriff's office is kind of an unknown entity in some ways. Presently, we employ 814 folks. They're organized into 3 separate divisions or work units. In the corrections end of things, our primary goal is to provide compassionate service, which encompasses keeping people safe. We want to make sure that we manage the day-to-day operations of the 2 facilities that Sarah mentioned. We have the Multnomah County Detention Center, or MCDC, and then we've got Inverness Jail, MCIJ. And we want to build on that collaborative work environment that offers support programming, medical staff, and our members work directly inside the housing unit. So there's 2 different models of correctional services. There's indirect and direct. We're direct. We put our deputies in contact with the folks in custody. Now, just to keep in mind, the sheriff's office has the correction side of the house. County Health has the corrections health side of the house. So while we work hand in hand with our healthcare partners, they actually are part of a chain of command, if you will, of another part of the county organization that we don't actually control or fund. And so I think that's one of the challenges for us in providing service to folks. And then we also have a large and growing law enforcement responsibility. Its primary goal is to provide round-the-clock professional law enforcement services, the kinds of things you think of when you think of policing. So we have one of the largest police departments in our deputy sheriffs that patrol contract cities such as Wood Village, Troutdale, Fairview, Maywood Park, and then those large unincorporated areas of Multnomah County. So all the way out to Scappoose on the west side and Dunthorpe and near Lake Oswego, and then all the way to Bonneville Dam and Hood River and that iconic gorge area that we all love. We take about 6,000 calls for service in our patrol area, and we have 280 square miles of patrol service, 110 miles of waterway that we provide river patrol. We do the civil process out of our law enforcement division. So when the court has matters that they want to have folks taken care of, like restraining orders, we're the deputy sheriffs that do that work. And then we've got about 3 million visitors to the gorge. And we know we're going to have some challenges this year after the Eagle Creek fire, because a lot of that area is really damaged, and people are going to want to see it and hike it, and some of it isn't safe. So we've got that responsibility as well. And then finally, our our business services division provides a professional support to the agency. Everything that's not directly related to custody or enforcement, the fiscal services, the training unit, planning and research, IT, all of the background things that make an agency that's as large as the sheriff's office operate. I want to just mention to you that we have in the corrections side, the Portland Police Bureau is the largest provider of folks to us, but we service the entire county. So we have adults coming into our custody from Portland Police, from Gresham, from our deputy sheriffs, from parole and probation. So there's a lot of ways, U.S. Marshals, a lot of ways for folks to come into our custody. We book 35,000 people every year. So we got a lot of folks coming into our booking facility, which is in the basement of the Justice Center. And that's one of the areas where there is unfortunately more force than we would like. But to keep that number in a little bit of context, we book 35,000 people. So you can imagine our daily volume is pretty high. We only use force on average once a day in our corrections division, anywhere in any of our facilities, including the booking facility. So force is a very small part of our overall work that we do. Those 35,000 people that walk in the door, 30% of them are recogged. So they go through the process and they're recogged immediately. So they're released as soon as we can get them out the door, they're released. And that's a pretty high volume. A lot of other counties across the United States are studying our processes and adopting those models so that people that can be safely supervised in the community in some fashion can go through that process. Out of that 35,000, 30% are recogged. The others are in custody. Many of those are released at arraignment. So that next day a judge sees them and releases them from custody to maybe a little bit higher supervision, like close street supervision or other types of supervision. The ones that do stay a little longer, our average length of stay right now is 12 days. So if you think of, if you look at jails all across the United States, the average length of stay is 24 days. Our average length of stay at 12 days is the lowest in the United States. So if the gold standard is getting people out of custody, we're on that podium. And there are very few jurisdictions that release people that quickly. Many jurisdictions hold people 30, 40 days. That's our average length of stay. So I expect our staff to, I call it relentless compassion. I want them to treat people with dignity and respect. Our agency has to embody the concepts in procedural justice where we're focused on providing compassionate care. We treat people with dignity and respect. We listen to people, and we want their voice to be heard in our processes. So at the start of that, I'm going to share a little bit of the challenges of managing a large, complex organization. The start of that is policies. So that's what guides our employees, and it's not a sexy thing to talk about, but I want you to be aware of it because it's really important that you know that our policy process has gone through significant revision in the last year and a few months since I've been elected sheriff. We allow for stakeholder input. So our policies are on the website. We put them out as we are revamping our policies. We put them out for your input. And we give them to specific organizations like DRO and the ACLU and other groups that we know have interest in certain policies to review. Our restraint policy, so that's a really important part of what we do is restrain people. So our restraint policy is going through that revamp right now, and it's on our website for public review. As well as that public review, we also have our employees and an opportunity for them to respond and provide their insight. And then our labor organizations. We have 3 labor organizations that our employees belong to at the sheriff's office, and we encourage the labor review as well. And those processes then make for a better policy process for us. It's been in place for a year, and we've had a lot of substantive matters that we've been that have reviewed. Our confrontation management, we call it use of force, but really it guides our employees in de-escalation and other tactics that they can use to use less force. That's a new policy for us. We have a prohibition on bias-based policing that follows the new state law. As I said, our conditional use of restraint policy is up right now for review. And these are all ways that we inform the next step in our process, which is training. And the training unit plays a significant role in ensuring members possess the knowledge and the skills necessary to provide a professional level of service that meets your expectations and mine. Now, training touches everybody in our organization. We're very fortunate that our chair and our commissioners support this work and have provided additional revenue to fund enhanced training. And Sarah touched a little bit upon it, but this past summer, we put all of our corrections folks through mental health first aid, and we taught them new de-escalation tactics to help them in their work inside of our jails. We want to make sure that our processes are informed by court holdings, new laws, certification. We've got somebody here from DPSST. They do the certification processes for us for both corrections and our law enforcement folks. Best practice, we're constantly looking at what other jurisdictions are doing, and then of course meeting your expectations as community members. We also have audits, and if you go to our website, you can see the DRO made recommendations. At the same time, we brought in an expert from the National Institute of Corrections, which is part of the Department of Justice, to do a review of our corrections division. And then every year we have a grand jury that reviews our jails. So those all happened within a fairly short time frame. They touched on a lot of common themes, and so we coalesced those recommendations into one audit package, and we put it up on our website. So you can go there and you can see exactly what we're doing, what we are, where we're at in that process, and the timelines for accomplishing some of the things that are still outstanding. We have a 180-day training plan. So we just met yesterday with the training unit and talked about we're in a 6-month training window now. What does the next 6 months look like? What is it that we are trying to accomplish? What are the needs of the organization? We really see a need and a gap on a national level to providing corrections deputies with that crisis intervention training that law enforcement has. And Nicole will talk a little bit about it. She was our training unit manager before her promotion to chief deputy, but we scoured the United States talking to other professionals in corrections saying, this is that Memphis model that police officers use has really changed the dynamic on on the patrol side, what's out there for corrections. And unfortunately, there isn't really good validated training that is appropriate for corrections. We may be at the forefront here in designing what that looks like. And we've got, as I said, somebody from DPSST here today, and we chatted about how do we design that curriculum and get it embedded in our jail systems here. Department of Corrections is also interested in that as well. So the next step in that, so we've got policies that guide people, we train to the policies. The next thing is to put them into practice and monitor what happens operationally. So we're in the midst of changing our culture, one that values communication as a means of productive employee contributions to make us operate efficiently. We believe that by using those same concepts of treating people with dignity and respect with our employees, that we're going to improve morale and service delivery in our jails and on patrol. We're expecting that our employees provide us feedback, both through policies but also surveys. And you're looking at the first survey we did, and we just completed it with some pretty surprising results. Typically, and this was part of a national police research platform that Rosenbaum and Associates did for over 100 police departments and sheriff's offices across the United States. We asked them to come in and do that same survey at the sheriff's office. Usually they see about 25 to 30% of employees respond back to surveys. You guys get surveys, right? And everybody's right on them. Yeah. We were really pleased to see that over 73% of our employees responded back to us. They really care about the organization. They wanted to provide feedback, and they wanted their voices to be heard. We also saw some really positive things in what they said about their supervisors. They felt that they were treated respectfully, that they understood their job responsibilities, and they received counseling and support instead of punishment for minor mistakes. Now, there's some areas that we didn't do as well. Some of the areas that we have to work on are around employee discipline. I like to say 95% of the people in the organization are doing really good work. 5% are doing something else. Well, the 95% expect Nicole and I and our other command staff to work on the folks that aren't doing as well as we would hope. Another area that I believe we have some challenges is just in improving I think the challenges that we have working in a criminal justice system that sometimes makes you feel cynical, and I know that a lot of you feel the same way. You see the system, the criminal justice system, our healthcare system, our mental health care system not working like it should, and not having the resources to really change people's lives in a positive fashion. And it can leave all of us feeling a little cynical or burned out. We saw that from our staff as well, especially with the folks that have been here 15 or 20 years. So that's an area that I think we have work to do. The last thing is systems of accountability. And we need, after practices, monitoring, we have to have systems of accountability. That's the key to legitimacy in our organization. They inform our professionalism and then lead to changes, and that cycle starts all over again about policy, training, practices, systems of accountability. They all interlink. We all have to be responsible for our actions, and we're actively recruiting. So if you know folks that want to be a member of our organization, we're looking for people right now to jump in and do this good work. Our frontline supervisors are a key to this. They contribute a lot to our service levels through their daily management. This year, as Sarah said, we're bringing on an employee information system that compiles information from a lot of different data sources that then supervisors can tap into to see how we're doing. It'll measure performance all the way down to the individual employee level so that we can see that we're doing better. We have a professional standards unit that holds us to the highest standards of integrity by assessing our practices and appropriately addressing complaints through a formal IA process. They report directly to me. I really believe that direct report of our internal affairs processes to the sheriff is true accountability, because frankly the buck stops on my desk, and that's where when holding people accountable, it's a complicated process. You work through labor agreements and state law and county policies, but at the end of the day I have to be able to hold folks accountable to the standards. So with that, I'm going to turn it over to Chief Deputy Nicole Morrisey to speak about our operations and the adults in custody that we're working with.
Thank you. Good afternoon. In the past year, Multnomah County has made serious strides in establishing pre-booking diversion options around the biggest behavioral drivers in our jail population. Those include homelessness, substance abuse, and mental health. MCSO has created the Homeless Outreach and Programs Engagement Team to serve as a safety net to human services, linking individuals in need of appropriate services in the field. Additionally, the Law Enforcement Assisted Diversion is an outlet for drug treatment, while the Unity Center is a mental health emergency services facility. Mental health diversion aims to support these efforts by focusing on subacute individuals with charges such as trespass. While an officer has probable cause for an arrest, they also have discretion to divert the individual from jail. The individual in custody must consent to the treatment over jail and authorize sharing of limited information between the mental health provider and the district attorney's office to ensure that help is pursued and that their charges may be dropped as a result of participating. While these efforts are in their infancy, there is much for the criminal justice system to learn from these efforts in the near future. Additionally, post-booking diversion options have been long established, with MCSO having the most influence over our closed street supervision program, which is an alternative intensive supervision program that provides pretrial services to those facing Measure 11 crimes, domestic violence cases, and clients with mental health concerns. Deputies interview defendants and conduct investigations to present to the court and assist judges in making an informed release decision. This program supports both offender accountability and reentry of the offender into the community. And at this time, the Closed Street Supervision Unit supervises approximately 232 people in the community and offers services and connects them and allows them an opportunity to be engaged in the community and with their family. With our facilities, MCSO manages 2 corrections facilities, which you have heard about briefly, which were built both in the 1980s. As we work with our partners in Multnomah County to create longer-term facility strategies, we are working in short-term to ensure our facilities promote personal safety and health. We appreciate that architecture may calm the conduct of adults in custody by reducing physical barriers that impede interactions. It ensures clear sights into all areas and incorporates design elements that promote positive behavior. Our members consulted with the Unity Center to improve one of our housing areas for mental health individuals. There were significant challenges, and we invested, by partnering with Unity, we invested in a new paint scheme, soft carpet and furniture, wall decor showcasing nature scenes, and we also installed chalkboards throughout the dorm and play music to further invoke the senses and provide for a creative outlet. In the spring, MCSO will make over the visitors lobby at MCIJ, also to promote family visitation and emphasize communication. MCSO is committed to the overarching goal of placing adults in custody in the least restrictive housing possible. And to meet this goal, MCSO restructured our operations to allow for 5 hours of available out-of-cell time per shift and shall be utilized for the purposes of attaining maximum out-of-cell time facility-wide. And this would include regular out-of-cell time where they're making, individuals in custody can make phone calls to their families, watch television programs. That also includes the programming that we are increasing at our downtown facility. The efforts applies to all adults in custody, not those just suffering from mental health challenges, thus removes MCSO from the federal definition of solitary confinement. We are incredibly proud of the work, and we appreciate our members' initiative to produce better outcomes for those entrusted to us. Also, MCSO, as discussed prior, works very closely with Corrections Health, a division of the Multnomah County Health Department. They coordinate the care of adults in custody. Our deputies and sergeants team up with mental health consultants and mental health personnel and medical personnel to form the mental health team. This team adheres to a case management approach, applying their respective professional lens to individual needs at every stage of custody. From there, a more personal and comprehensive plan is employed to serve that individual during their time with us. After working together for a short while, we have seen results. Corrections Health was able to expand the clinic hours, increase access for mental health services. With more privacy, medical personnel are able to hold meaningful discussions with their clients, which results in treatment. Better treatment informs discharge plans when leaving custody, and better overall outcomes for those that are in our facilities. When individuals stabilize and feel better, their behavior becomes easier to manage for the corrections staff. Overall, MCSO is grateful to our Corrections Health partners, and we will continue our team effort in this regard. With diversion, custody, and care addressed, MCSO is turning to preparing our adults in custody to re-enter the community. We currently offer a variety of programming aimed at holistically supporting those in our care. We worked with and have enjoyed a long-term relationship with countless service providers, yet there is work to still be done. With more out-of-cell time operationally in place, we are hopeful to fill this time with structured programming and options to better the outcomes for those that are released from our custody. Groups that provide programming are also interested in helping MCSO and Corrections Health facilitate a warm reentry. Presently, Corrections Health manages discharge procedures for our acute population, ensuring they have insurance to cover any treatment placement of services and determine whether the individual is eligible for additional benefits. The advice of the mental health team personnel also inform this effort. Meanwhile, MCSO manages discharge procedures for our subacute population, determining whether an individual is eligible for benefits other than medical, and provides information about additional services. And our goal is to have a discharge plan for all adults leaving our custody.
So we want to open it up for questions. I just wanted to close out by saying one thank you to Nicole. Katie Burgard, our program manager, was supposed to be up here presenting with me, and she was sick at the earlier part of the day and had to go home. So I said, Nicole, you have the short straw. You have to help me out. So I want to thank her for being up here. But, there are a lot of huge challenges and barriers to the work we're trying to do, and it's some of it is lack of resources. We're having this conversation today in close proximity to when our commissioners are making decisions about how to fund stuff in the budget, and we know that the county budget is going to start to have less revenue than is needed to maintain current service levels. So we're trying to do some innovative things inside our correctional facilities, like put additional resources, a mental health sergeant and deputy for better coordination and getting people out of their cells. Well, those are positions that we may lose. Or the close street deputies that supervise people out of custody, we may lose them. And that's capacity then that will impact our jail population. I will say we've gone from 1,310 jail beds, which we had for about 6 years. We had budget cuts. We're down to 1,192 right now, and it's 95% full. When we get to that 95%, we start what we do is we call it matrix releasing. We look at the lowest score, and that person goes out the door. Well, unfortunately, when we do that, it's a court-ordered process, but some of the folks aren't necessarily the safest risk to the community, and it's not always the best thing to do for them. Judge Jones, who was working on our mental health docket, had a person that he had placement for in the community, and that person got matrixed, released out before we could make the warm handoff. And then you have folks who, may have a treatment bed ready, and they get released back out, and they spiral back down into that addiction, and instead of a warm handoff to treatment. So those are some of the challenges we face. Certainly, as the budget comes up, I know our county chair and commissioners would want to hear from you on how to make this system work better. So thank you very much for listening to us, and happy to answer any questions that you have.
Interested in hearing from people who have firsthand experience, either working in the jail, spending time in the jail, spending time in other jails, family members in jails. So please, everybody, of course, feel free to chime in, you folks in particular.
Sure. Yeah, well, I'll let Sarah talk about DRO, but certainly the Sheriff's Office is using as many media outlets as possible. So traditional media, but we have a robust website and Facebook and Twitter and YouTube that you can go to and see what programmings we're offering and some of the challenges that our community's facing. A lot of the efforts that the local Public Safety Coordinating Council are engaged in are open to the public. So you can come to those meetings and see what all of the system providers are doing to make our criminal justice system work better in a more collaborative fashion.
Yeah, and DRO does a pretty good amount of communications work, so working with media and putting information out through our channels. But yes, people who have a diagnosis of a mental illness are much more likely to be a victim of a violent crime versus a perpetrator of a violent crime, and we definitely want to speak out against scapegoating of people with mental illness.
And so I have a question. It's actually probably best maybe for you to answer. So my question, and I deal with, I'm a prosecutor who deals with a mental health caseload, and so not only do I deal with criminal charges, but I also do the civil commitments as well. And so decriminalization of mental illness, that makes all the sense in the world to me when we're dealing with persons with a serious and persistent mental illness such as schizophrenia or bipolar. My question for you comes with, I think, a large amount of that population that also suffers from perhaps antisocial personality disorder. And I think what that creates is it makes that particular population that have both issues highly unlikely to be able to voluntarily participate in treatment because of lack of insight and because of, on the other side of it, manipulative or criminal behaviors. And so when I'm dealing with folks like that, when we try to deal with it on the civil side of it, so on the civil commitment side, the mental health side of it, what we're seeing is that state hospital and other facilities around the state, even if we get that person committed, they're not willing to take them because of what they see as criminal or antisocial behaviors. And so that kind of leaves jail as our only route to kind of dealing with the public safety issue. And so I'm wondering if you have, I think that's a pretty common issue, and so I'm wondering if there's any help for that situation.
I can speak to that a little bit. First, I think it's a false dichotomy to look at either civil commitment or incarceration, because there's a third option, which is community mental health and housing. And so we really need to build up that third option, which is voluntary. But I think, personality disorders, and I'm not a clinician, so, but personality disorders, from my experience and what I'm told, tend to correlate with a trauma history. And I think people have a lot of trauma related to their experiences with coercive care in hospitals and their experiences in jails. And I think we really need to create options that feel safe and welcoming and trauma-informed, and where we're providing the services that the person's willing to receive, even if that's just seeing a podiatrist or getting clean needles or a safe place to stay. So I think we really need to think outside the box. But I'm not sure if that really addresses the personality disorder diagnosis. That's something that I've struggled with in my own work too, whether to what degree do I buy that access 1, access 2 distinction.
Hi, my name is Sean. I'm a peer support specialist with the Behavioral Health Unit in Clackamas County. And so many of the people that we deal with are dual diagnosis with severe mental illness, but then heavy meth use too, particularly meth. I mean, other drugs, but particularly meth where I'm at. And what I've seen the jail system out there do, which is kind of a fail, is that like they'll treat the criminal part, but then there's not really a plan for the mental illness part, and then not really a plan for the addiction part. So just to like pick your brains, like what, in your mind, how would that all work together? Like how could you help all three of those kinds of problems? You know what I'm saying?
I do know what you're saying, and I'll tell you, I think it's one of the biggest challenges in policing is that you come across somebody, you get called, and I like stories, like Sarah does. So last week I was coming from the courthouse, headed back down to our office at the Multnomah building, and covered a central precinct officer on a hot call. And there weren't enough officers to respond, so I said, yes, I'll go. I'm in uniform, and I still like being a police officer. So it was a man at the Chipotle at 2nd and Yamhill, and he had his pants down, and he was threatening people, and they were calling because he wouldn't leave. So I'm covering on the call, get there. The officers engaged in conversations with the man who's now outside the restaurant, and neither of us could tell whether he was high on something like meth or if he had a mental health issue or both. And I don't know how you do that in that moment out on patrol. So the officers they have a really tough job, and they do the very best they can. Well, the same thing happens often in our correctional system, especially when, in our system where we're 30% of the people that walk in the front door are leaving as fast as we can process them. Unless it's a fairly significant issue, a lot of them are going out the door without any real discharge plan. When folks stay, we rely on Corrections Health to help us figure out what's the right track. We do have a unique program in place in Multnomah County at Inverness. We've got a treatment readiness dorm. So folks that are adjudicated and they're likely to be, or we call them, they're part of the Justice Reinvestment Program. So people that would have gone to jail, to prison, we're now trying to hold them locally and get them into treatment to break the cycle of criminal behavior. Some of it is around addiction, some around mental illness, but we have a treatment readiness dorm for folks that are going to be discharged to treatment, and VOA is coming in and providing services in that dorm. So far, it seems to be working with that population. Some of them are dual diagnosis, and being around peers seems to help, and again, it's challenging work, so I don't have easy, simple solutions for it.
One other, if I can just respond really quick too, services in the community are reimbursed by Medicaid, medical services, but our jails and our state jails come out of the county budget. Our state hospital comes out of Oregon's general fund, and it costs $240,000 per person per year at the state hospital. And so for people who go down to the state hospital to receive competency restoration services because they're charged with a crime and they're not able to aid and assist their lawyer, 40 some percent of those folks are charged with misdemeanor crimes, and they can stay for up to a year at the state hospital on a misdemeanor crime. So what I'd love to see is a mental health reinvestment funding stream where we'd reduce our population at the state hospital, close units at the state hospital, and reinvest that money locally in behavioral health services. Wouldn't that be cool? I'm just going to pass it over and you guys just pass it.
Yeah, I work for the Forensic Act team through Cascadia. And we have someone on call 24/7, but what we're having a barrier for us is that when a police officer is called out for a crisis, we're not having that information. And so an opportunity to intervene in a potential situation that would put someone in jail is missed because we're not being contacted. So my question is it standard protocol for a police officer to call the Multnomah County Crisis Line to see if a person is connected to mental health services? Or how does that work when a police officer is called out?
Well, first, let me say thank you for your good work at one of my favorite organizations. Cascadia has been a real partner with us, both when I was at the Portland Police Bureau and now at the Sheriff's Office. And we created the mobile crisis units where we partner a Cascadia employee with mental health skills with a Portland police officer. We've got one in each of the patrol districts in Portland, and they're supposed to kind of work on that. So I'm sorry that the information isn't getting to you better. I think that's an area I'll bring up with the behavioral health unit. The other component we created was a behavioral health unit. The Portland Police Bureau, the Sheriff's Office now participates on that to staff these types of issues and find a way to work around it. So I'll ask. I think that's a great idea to have officers, if it is a person in crisis, call the crisis line and figure out if there's something that we could do to support whatever you've done already in the community. So thank you for that idea.
Thanks.
I just have a question for you guys, actually, because I'm from Lincoln County. I'm a prosecutor, and I know that a lot of our mental health people with mental health issues that come into the jail, they have trouble with them from a security standpoint, and so they end up being more in solitary situations truly because of I don't think they feel like they have any other choice. So I was just wondering how you guys, with this increased time out of cells and things, like how do you address that? So if you're not using restraints, you're not using solitary, how do you keep the whole population safe, especially when you've got someone who is having a major safety issue, crisis type thing?
Yeah, I think we brought on a sergeant and a couple of deputies to work with that population and with our corrections health team and try and be really intentional about taking the time to have conversations and trying to get people to that are in some sort of crisis to participate in getting out of their cell into programming. It's really challenging, and it takes a lot of patience and some special skills. So we've, with that team, that mental health team, we've tried to provide them additional training that builds on their skills and some additional knowledge about how to best work with people in crisis. But I think that is one of the challenges. As Sarah said, when people are in those, they get in custody, they're staying in custody for whatever reason, and they seem to spiral down. I mean, I think that's one of the challenges for all of us in the correctional field is how do you keep people from going into a worse state than when they came in? Because our goal is that they leave our custody better than when they came in.
Right, and you guys are probably sometimes, I know, right, like they're going to be headed maybe to the hospital, but there's a delay, and so you're trying to deal with sort of the situation that you have right then, and you can't release them, and so what are you going to do?
Yeah, these are folks that aren't going to get out of custody typically until a judge says, here's where they need to go. And sometimes it's community-based treatment, but other times it's a state hospital or something else. So, but for us, having teams that we've dedicated to working on that very problem we're seeing benefits from it as we're getting people out of their cells and into recreational opportunities and more programming.
Awesome, thank you.
Hello. I was wondering if when you guys see articles or TV things about the Scandinavian prison system and kind of those things, like, I feel like everyone has seen those at this point where it's a very trauma-informed, kind of idyllic way of doing prison. And I think that, I don't know, there's a lot of cultural reasons that you can't just import a system like that to here. But I just wanted to know, when you guys see those things or read articles about that, what is kind of your personal feelings about it? Is it frustration? Do you feel like, I wish we could do certain things like that, but here are like the things holding us back? And I just wanted to know kind of personally how you feel about that without going into the reasons that it can't work, because I think that, I don't know, I feel like I've heard those and I understand them completely, but is that like the goal system that you'd want to work for like 20 years down the line, or does your dream system kind of look something different than that? And then I guess my other question that I have is just with the employee surveys that you did, do you guys do surveys like that to like customer satisfaction surveys of people that are being discharged or leaving, or people that are actually in the system, to see how they feel about being, like, if they feel respected by guards and things? Or do you measure that in any way?
I'll answer that next, because that's our next step. The idea is to both find out from the adults in custody as they're leaving our custody, what was your level of satisfaction? Were you treated with dignity and respect? Did you have the information that you needed to be productive and to understand the system? So yes, we're going to be doing that. We're also doing surveys of people who are victims of crimes or engaged with our deputy sheriffs out in the law enforcement community. So let me go back to that other interesting thing. So we had a Department of Corrections. I think she's number 2 in the hierarchy there. And one of our Criminal Justice Commission members traveled to Norway to study their system. And they came back, and I had lunch with them to hear about their experience, and frankly, it was inspiring. Their system is based on rehabilitation. So the courts and other folks deal with what's the right punishment, if you will, or whatever you want to call that side of it. The correction system deals with rehabilitation. So their focus is, regardless of what you did, our job is to rehabilitate you so that you can, when you leave our custody, not recidivate and be a part of our community. I think that's where we need to head too. Now, how we get there, I'm not there, I don't know that yet. I'd love to go to Norway, but I don't know that anybody's going to pay. They had a grant to do that. So, but I found it inspiring, their stories. And I think that what I've asked Nicole and Katie to do is let's start by doing a discharge plan. So everybody that leaves our custody, we have a plan. A warm handoff to, if they're homeless, to a housing provider, if they have addiction, to a treatment provider, if they need resources around mental health. And then inform our staff about what that plan is, because we know a lot of folks, as Sarah said, they come back into the system. Again, very few people stay very long in our Multnomah County jail system, but a lot of people do come back. So I think it'd be really beneficial for our staff to understand what the plan is, for that person to understand the plan, and then we all work together on it so that and really from a healthcare model and from a harm reduction model, if that person got arrested 20 times in 2017, in 2018, let's cut it down to 5. And that we have a plan in place for everybody that comes into custody so that we're all working towards breaking the cycle of recidivism and helping people heal. And our focus in corrections is on rehabilitation, not on punishment, but on helping people be part of our community again.
Yeah, I think that the two things that we try to push are, providing kind of baseline of services that people need, but that's really expensive. Like I said, state hospital, $240,000 per person per year. If we were to do that kind of budget on the scale of mass incarceration that we have in this country, that's not feasible. And it's not we could do that so much better in the community. So we really need to focus on reducing jail and prison populations so that we can use that money to try to help people while they're there.
So you're telling me with $240,000 that someone that has a mental breakdown on the streets gets assessed. So you're saying this person does not have is not competent enough to now take care of themselves mentally or physically, and for $240 you're going to rehabilitate me to be competent for 1 year at the state hospital? What's 1 year at our jail? MCDC or MJ?
It depends on the, I'll let you do the math, Art, but it's about $120 to $150 a day, depending on where they're staying in the facilities. Obviously, if they're at MCDC, it's more expensive because it's a higher staff ratio and single cell location as opposed to Inverness where we have dorms and you've got 57 adults in custody and 1 corrections deputy monitoring that. So, the cost varies depending upon where people are at in the system.
Well, I think that's where some of that problem is. $240,000? Think about it, for one person. I mean, if there was more, and we hear it, more of that peer support needs to really be there. So someone that's had a mental breakdown before that's able to get them back to a self-sufficient way is in those state hospitals as well, so that because they know where they're going, they know where they've gone, they know where they're going, and they know what this person really needs help. It brings a lot of that money down, and that's an outrageous fund. $240,000 for one person compared to almost like, what'd you say, 150 a day. Someone's there. That is trauma for themselves once they walk out that door, and you want to ask them about satisfaction, because most folks that go to jail and get out, they got to go to court the next day or the week later, and then they have to stand in front of a judge that says, hey, if you do it again, your fine's going to be this. Well, we're going to give you a fine because we just charged you $64 for things that you didn't ask for. And people still don't see that underlying number of services that you receive there to get that evaluation. Trust me, I know. I know, and you know. I've been in your custody quite a few times in the past, and I've seen those underlayer numbers, and it just becomes like, oh my God, I have this on my record now, and that's just trauma right there for that person. So it's a cycle that keeps going. And back to your, I think it was the one about assessing the person right there. One, there's really no way of any safety for that person trying to be assessed, because one,
Is this like a pre-booking assessment?
Pre-booking. When you bring them in, they already have all these officers that are around them, and they've got to get their picture taken, they've got to get their, hands printed, and then they get taken over there. That's 2 more trauma pieces on top of whatever you pick them up from outside. So you're just adding to their trauma, and that's those little things that keep going. And why would that person not have a mental breakdown? And it could have been a small, quick thing that was out on the streets that happened. And to the guy's point, like the difference between a mental breakdown and drug addiction, it's the same way. It's got to be more of that warm handoff that you're talking about, but more in a peer support way, and not that, having that officer. That's where some of that has to be as well. Because they're not going to talk to the officer. The officer's got a gun and things of that sort. So they've got all these other things that are going on with them.
Yeah, and I think, our DAs are elected officials too, and we can hold our DAs accountable to, if DAs are making charging decisions to charge someone with a misdemeanor crime when the underlying issue is mental health or addiction. They're throwing hundreds of thousands of dollars of state money down the tubes when that could be invested more wisely.
I'm sorry, that's a very difficult one for me because I'm a DA assigned to the mental health docket. And the reality is, in my county, sadly, well, first of all, you have to remember there's victims of a lot of these crimes. So we have to consider them as well. And secondly, the sad reality is there are no mental health facilities in my county. So sometimes the only way to get someone help who's in crisis is, if they've committed a crime, to have them go through the system and get help that way. It may be the most expensive and it may be crazy, but it is the only way. And I literally have victims sometimes who are family members working with me on this. So I recently had a guy who was schizophrenic. He'd been in and out of jail, hospitals his whole life. His mother is a mental health practitioner, and she and I worked together to do what we both thought was best for him. And at the end of the day, I dismissed the charges. But without getting him into the jail, I couldn't get him the help that she and I both thought that he desperately needed and was refusing, frankly. So while so much of what you're saying resonates with me, the reality that we're dealing with is so different sometimes. And so I just wanted to say that.
I totally hear you on that, and I don't mean to oversimplify it. I think the way criminalization of mental illness happens is not through anybody's ill will. Like everybody, we all want the same things. We all want people to access treatment and services to help them stay stable in their communities. And I think DAs can be a really powerful voice to explain the reality that there aren't those services, especially in rural areas. I think in Multnomah County, we're privileged to have access to some services that don't exist elsewhere in the state. But I think, I think there's a lot of common ground there because I know those decisions are not easy. All right, who else do we have? Douglas has had his hand up a few times, so back here and then up there.
Ignoring me.
Sorry.
No, but anyway, the state has a whole list of evidence-based practices that could go into. I understand the whole perspective that at this time, trauma-informed approach may not be appropriate for you, but there are others such as CPS or whatever that you guys could do. Not just meeting your needs or their needs, but coming to an agreement and meeting the needs of both and trying to avert jail time or something through active engagement, I guess, or in the community. And it's kind of like a diversion program, I guess. But anyway, it's good to hear that you guys are doing something because I've heard some pretty horrific stories about MCDC, and quite frankly, I was going to ask you about a few of them, but I'm glad that you are doing something anyway.
Number of questions come up. I don't know if things have changed since the fall of 2016, but a small percentage of the jail population goes through TSI, and so you deal with, I think that was maybe like 60 people back in the fall of 2016, but still in a high custody environment. It actually would be harder to leave that than to walk away from work release centers in a lot of other counties. But when you talk about building individual accountability in inmates, I think there's some potential for that, both increased work release centers and more use of TSI. But the other thing that's really, I think, traumatizing when we've just had the judge from Florida speak about a human rights and a civil rights perspective is life and liberty. And we're talking about misdemeanants who, although they might not be able to assist in their defense were semi-functional human beings, and now when they're only facing 15 or 30 days of detention, instead we decide that we're going to reward them with 60 or 180 days of competency restoration in the state hospital that costs $120,000 if they stay 6 months. I think that there's a significant aspect of overlooking human dignity. I mean, I want everybody to be able to access care, but I also don't want the only care available. We have the lady DA from here, from Lincoln County, 41 people to OSH, but that's certainly understandable in a county that doesn't have any other mental health treatments. A bigger county, Columbia, only 13 people sent to OSH. So I'm lucky to live in this Multnomah bubble, but we also have to look at our neighbors and our brothers and sisters and fellow Oregonians and say, where are the services? When we talk about the law enforcement budget, we got to stop talking about it in isolation and always talk about it with community-based mental health, not massive things like OSH budget, but community-based mental health. But what do you think are the roles for growing situations like TSI and almost zero custody individual responsibility sanctions?
So for those of you that don't know, TSI is a program we have it's called Turn Self In, and it's an alternative for judges to use to traditional sentencing, where you're at court and the judge says, I'm giving you 30 days for your third DWI conviction, and we know if the person is taken into custody and spends the next 30 days, what's going to happen? Well, they'll lose their job. And in the past, we had a work release center in Multnomah County. Budget cuts, that we lost that. So we created a small Turn Self In program that judges can use. It's on weekends. So you're spending, if you got 30 days, you're spending the next so many weekends in custody. And we have jail staff that open up part of the jail just for that population. Anyway, it's one of the budget cuts that we're facing right now. So that program may go away in our current round of budget cuts. And it's another way for judges to allow people to stay in the community for most of the time, stay connected to their families and their jobs. In budget cuts, our work release center's gone away, and this may go away as well. So, about 60 a weekend are in our TSI program.
Do you have any dates for like the camera installments or any other stuff you have going on?
Yeah, the camera installments going on right now. We're working with a vendor to do the wiring and then the installation of the cameras at MCDC. And again, I think that's a good thing for accountability for our staff as well as for the adults in custody.
I think we have time for one more question.
Hi, to just piggyback off of what he was saying a little bit ago, my question is, you guys are focusing a lot of training on de-escalation skills and all of that. Is there any training specifically for prevention of crises and trauma support for staff in vicarious trauma?
Yeah, I'll let Nicole answer as well. We have started to provide some of that information on staff well-being, and we've stood up a peer support program inside the sheriff's office. We had the traditional employee assistance programs, and we have a really vibrant chaplaincy program, particularly for adults in custody who are members of a faith community. So we have 52 volunteer chaplains that meet with inmates or adults in custody if they choose to. So we have a responsibility to provide that to folks in custody if they desire it. But we're doing that with our staff as well if they want to be part of a faith community. And then also peer support's really important. So we've stood up those 3 legs of employee wellness and developing that as well as additional things for the staff.
Yeah, in addition to the peer support program, we also have a corrections critical incident response team. and they receive about 48 hours of training so they can respond to our facilities when we have critical incidents, so we can assure that our staff feel valued, feel like they're heard, and that we're supporting them along the way to ensure that they are healthy when they return to work if they were to be needing a couple days off or additional services. As part of the training for our staff as well, we began to move through our training program. We started with the mental health first aid, so we trained all of our staff through mental health first aid to start allowing them the opportunity and more skills to recognize, so maybe they could intervene prior to crisis. And again, we've spoke a great deal about our mental health team that works collaboratively with our mental health consultants. Our sworn staff work collaboratively with our mental health consultants and medical team. And because they are familiar faces to those that individuals in custody, even if it's 7 to 10 days, it's the same team that comes to the area that they're housed in to interact with them, to engage, to encourage out-of-cell time. So I think putting that program in place and assigning 2 specific people from the sworn side and working with the providers, it really allows for them to engage on the front end prior to potential crisis.
So thank you all very much. We really appreciate the opportunity.